Are we ready to start the new session?
The most exciting session, I would say.
All right, so good morning again, and we are very pleased to be here today with you guys. And my name is Dragoslav Popovic. I'm consultant to the World Bank, and I have 25 plus years of experience in the field. And beyond that, go ahead.
Hello, guys, can we have your attention, please? Thank you. My name is Rialda, and I'm also coming from the World Bank, and my primary task is actually working on the flagship program. So today our task at hand is to talk to you about behavior and behavior change within the flagship framework.
So I think over the past couple of days we were talking a lot about health sector, about financing, about benchmarking, about priorities, about payments, about health insurance. And today we will move our focus a little bit to our primary customers. And we will talk a little bit about populations, about people that we need to serve, our clients, and how their behavior actually affecting all the rest we're doing. And of course, how can we make it to work in supporting whatever measures we are taking from the systems.
Okay, so let us start. In our preparation for this session, we wanted to kind of find a good example how we can pique your interest to show you what the power of behavior is. And we hope that this example will actually do that. This is a real example. So think of a country where 50% of deaths that are occurring due to car accidents is to drinking and driving. That sounds like a lot, right? So it is an obvious societal issue that needed to be addressed. I'm sorry? Oh. That's exactly what this campaign ended up doing. So let's put it in a context. Think you have 5 guys. They're all in their early 20s, 22, 23 years of age. And 4 of these guys enjoy drinking, which is kind of normal. I think it's a norm in Armenia too, right? They go out, they get drunk, no big deal. But the 5th guy feels a little bit like an outsider, like, I kind of don't belong with my friends. I'm kind of less of a value. This very campaign rolls out, and what happens? The identity of this 5th individual changes. Now, he's not going out just to be with his friends. No. He's now a value add. He's societal value. He's going out to actually save lives. So tomorrow, when he meets up with his friends, he's going to say, I'm like, well, here's your aspirin, here's the water. I'm happy that I came out along because I was able to save your life. So that is the power that behavior can have. And you may wonder, how did this translate into numbers? The mortality due to drinking and driving was dropped by 30%. Now you may also wonder, why was this so successful? Why was this done? First of all, it was a big issue that had to be only addressed on population level. It cannot be done one-by-one basis. Second of all, it was asking just for a modest change in behavior. We're not telling people, do not drink. That would not have worked, not with the 20-year-old guys. It was saying, you can drink, that's fine, but let's actually change our attention to somebody who's already not drinking so they can be a value add to society. And of course, no alcohol industry was going to oppose that kind of campaign, so that was recognized. And as I said, it was an issue that needed to be addressed on a population level. So that is the power that behavior can have. So today we have 3 tasks, and we're hoping to achieve them. One of them is looking through the behavior and persuasion through the health flagship framework and how it can help achieving health systems reform and path to UHC. The second task is to look at different approaches to behavior change. And finally, we wanted to address a specific public health problem and use a strategy of behavior change to do that. But before we do that, we wanted to come back to our famous framework and just kind of give you an overview once again what we're doing here. So we keep mentioning control knobs, control knobs, control knobs. Doesn't really matter how you call them, whether you call them pillars of the flagship program. The point is they're pillars or the control knobs or the variables that you can use to achieve policy change. So you can use regulation, financing, organization, payment, all of these things to achieve your ultimate goals of health status, patient satisfaction, and financial protection. And to kind of measure how you're doing on achieving those goals, we're using efficiency, access, and quality. And that is within the framework of the health sector. But this is very important. We're stepping out of this framework, stepping out of this health sector and saying all the other sectors, just as much education, finance, agriculture, transport, they're all contributing to achieving these ultimate goals in achieving the human capital, economic development, and overall well-being of humans.
Yeah, I think what is also important that behavior is a specific goal among these 5 that we have. And, you know, if you improve behavior, people's behavior, you would expect to have gains in efficiency, quality, access, and then in ultimately in the health status, customer satisfaction, and risk protection. But there is also, I think it's very important to look at the other way around. You know, whatever knob you are using, if you change the financing, if you change the payment, if you change organization or regulation, you need to understand how those changes will affect people's behavior. And that is extremely important to be able to really implement whatever you want. To look at how that affects people's behavior, how you can adjust whatever you're doing to get maximum out of inputs that you're putting in the health sector.
So we would like to ask you to answer these 2 questions for us. We just mentioned 2 measures of intermediate outcome, or I'm sorry, 3 of them, access, efficiency, and quality. So the first question would like for you to answer for us, and if you can raise your hand, is what are the examples where household or individual behavior impacts access to services? Can anybody give us an example of that? So what are the examples where household or individual behavior impacts access of services? Anybody?
People's behaviors? Yeah?
Sorry?
The improvement will be increased, and the awareness raising is very important to provide a due coverage.
The people's behavior. Okay.
Let us give you an example. So think of the tuberculosis and think of a patient who has treatment for tuberculosis. He is on antimicrobials, but he's not taking those drugs, right? For whatever reason that might be. Yes, you wanted to say something?
Okay. The willingness to take drugs every day or պատասխանատվությունը. So this is
The responsibility.
more.
Good.
That's good. And how about the examples where provider or institutional behavior impacts efficiency or service of quality of care? Oh, we have. Unless somebody else wants to.
Please, yeah.
մի կողմից
On the one hand, the institute itself provides the drugs and provides the accessibility so that the behavioral change, that is, delivers the drugs to the patient in due time. And another change might be the behavioral change in physicians and their right attitude to the patient so that the patient will be ready to get the drugs on a lengthy period.
That's actually really good, and we will be addressing that. So thank you. Any other examples that you guys are willing to provide for us? Okay, shall we move on?
repeat this example of a TB?
Yeah, I'll just continue with the TB example. So, as your colleague pointed out really well, TB is an issue in this country, right? And antimicrobials are prescribed. However, it happens very often that patients are not taking those drugs. But that's not the only thing. There is also a risky behavior that comes very often with that, whether that's alcohol consumption or smoking. And along with that not taking of drugs, what we really are doing, or what that patient is doing, is leading to increase of multi-drug resistance. So we see that the efficiency and quality are also being impacted. Yeah? Does that make sense? Yes?
Yeah.
Go ahead.
One question, I perceive access as the patient wants to get wants to have this treatment, wants to get to the hospital, wants to be cured, but the patient is not able, or the patient can't get access. Whenever you don't take medicine, you don't take pills. Does it mean that you don't have access? It's more like something behavioral. You have basically this opportunity to get these pills, but because of your behavior, you don't.
That's exactly a very good point. So what you're saying is we have a patient who has access to the medical worker. He got treatment. He has the drugs. He go back home, but then he starts playing on his own. That's exactly the behavior. And what is also, I think, important to this example, in the beginning, this patient is making harm to his own health by having the inefficient treatment. But when he starts drinking, when he gets into some other behaviors that could result with a multi-drug resistant TB, then it's then becoming a risk for the broader population. And then he may get involved in other behaviors that may actually also risk others, not only himself.
So here we have an individual behavior impacting population. I think it's quite obvious from this image that whether we like it or not, we're social beings. We impact people around us. We could be an introvert, doesn't matter how much, just keeping to ourselves. But what I do as an individual will impact my immediate circle, but it doesn't stop there. Actually, it goes further. So let me give you an example. My sexual practices are going to be translated on a population level. If I'm using a condom, that's going to be translated in HIV incidence. It's also going to be translated in STDs. Or think of it this way. Now we're actually in epidemiological transition in this country, right? Sarah talked about this, and we actually explained this quite a bit. And it's a serious thing. So think of a person who is obese. Right now, that might impact their quality of life, whether they can run, whether they're going to have stroke or heart attack, doesn't really matter. But in the long term, because these are really diseases that have chronicity, that they're long-lasting, that burden is going to be translated on population level. So we have to be thinking about that whatever I do as an individual, maybe momentarily I'm just impacting myself, but in reality, particularly in the long term, I'm actually impacting people around me and on further greater scale. So then you probably might ask, why do we engage in risky behaviors, right? Why do we do it? We know drinking is bad for us. We know smoking is bad for us. I know if I do that I'll end up having, impacting my vessels, having a stroke, heart attack, doesn't really matter. If I overtake antibiotics, it's not obviously good for but why do we do it? Well, different scientists try to explain this. Psychologists, sociologists, behavioral scientists. And there's so many explanations that we don't necessarily have the time to address all of that. But one thing that keeps coming out is immediate satisfaction, delayed gratification. We are wired in such a way that we'd rather get satisfied right now than thinking about the consequences later on. So think of it this way. I had back surgery. It's excruciatingly painful. So I'd rather be taking the pain meds now as opposed to thinking, well, later on down the road, I may actually end up having an addiction to the pain meds. So this is one of the things that we try to explain that our rationale is not necessarily always present when making these behavioral choices. And one very important thing is that we're wired by our habits, what we do day to day. So whether it's that drinking coffee or having that first cigarette in the morning, doesn't matter. The habit is extremely hard to break. And if we succeed in breaking habits, we would actually be far more successful in changing the behavior. But as we're learning, that's not so easy to do. So what we really want to draw your attention, that behavior can change on all levels. On individual, which is really hard to do. That's our knowledge, our attitudes, our beliefs, and our habits. On interpersonal, people that are in my immediate circle, Nedim, Dragoslav, Sarah, Ajay, they actually impact what I believe on day to day. Our community within the World Bank actually has that impact even further, which is seen in institutional organizational behavior that Ian was trying to tell us about. And finally, the long-lasting behavior changes that we can see are within the policy making. So that is what we are trying to explain with this model. So now we're transitioning to the next part of our session, trying to see different approaches to the behavior change. And what I'm asking you kindly, please do not pay attention to these titles. They are really for the behavioral scientists. The names do not matter. We're just putting them so you know that there are different types of changes to behavior. What we really want you to think about is the approaches that we're trying to use. So what we're doing with the socio-ecological model, what does that really mean? It really says that people are far more likely to change the behavior if their environment and a policy that are present are appealing to them. It's going to make them far more willing to change the behavior. But what really matters is this individual. Individual is at the center. So what we are trying to do is change the behavior individual through all these different frameworks. And there is communication going back and forth. The individual is impacted by family and networks, by community, and by society. And the further we go out, the long-lasting behavior changes are successful. That's why the power of policy is so strong. Any questions? Health belief model. This is the role of feelings and our beliefs when it comes to the behavior change. And Dragoslav is going to walk you through this example.
Yeah. All right. Okay, so that model, imagine that we have a person who feels that it's related to the condom and the prevention of HIV/AIDS. And how people behave in principle is basically, it's very important that they feel that there is a negative health condition with the HIV, and that negative health condition can be avoided. Person needs to have a positive expectation that by taking recommended action, actually by taking a condom, will also avoid a negative health condition in relation to HIV infection, that the condom is effective in preventing HIV, but also a person needs to believe that he or she can successfully take this recommended health action, so that he really or she has a condom, know how to use it, and if all of these elements are kind of in place, then there is a chance for success. We will use this model a bit later in our presentation to discuss with you how different is an issue with the HPV vaccines that was recently a part of a great public debate in your country and some other countries as well.
So the bottom line in this example that we really want you to take is that my belief and how I feel about performing a behavior is going to impact whether I'm going to perform it or not. Just think of it this way. If I believe that I can climb Mount Everest, I'm going to do it. There's nothing that you can actually tell me that I cannot do. But if I'm scared, if I'm afraid, doesn't matter what kind of incentive or promotion you give me, doesn't really matter. I'm not going to do it. So our belief in ourselves that we can perform the action is actually going to result in doing the action, not just you can do it or just providing the information about doing it. Does that make sense? Okay. So this model beautifully exemplifies how behavior change occurs through stages. And it really, we have to be aware of that. You cannot just wake up one day and decide, I'm going to change my behavior, whatever that behavior might be and how negative it might be, and I'm just going to decide to do it. No, behavior occurs through steps. It takes time, and it's completely okay when you're trying to learn a new behavior, particularly if it's a healthy behavior, that you're going to go back and forth between these steps. So what we're learning from this model is that through different stages, first of all, I might, at the very beginning, I could be completely unaware that I have a problem. Smoking, to Sarah, might be a problem. To me, I'm like, no, that's something I enjoy. That's not a problem. So I'm pre-contemplating. I don't even want to deal with it. When I get to the contemplation stage, I might be, I heard that smoking could be an issue. I might be willing to change it, but I'm not ready to do the action. So now, preparation comes as the next step. I tend to take the action, but I'm just yet not quite mentally ready to do that. And then action, woohoo, I'm actually doing something about changing this behavior. I'm actually trying to change it. And then finally, we get to the maintenance stage, we're trying to keep the healthy behavior going. The bottom line is that you can go back and forth. And the power of our communication, the power of our policies and what we do and how we conduct ourselves is that we are trying to encourage people to stay at the maintenance stage. That doesn't necessarily mean that we don't want to push them kind of up on all these different steps. So let me give you a more practical example to bring this home. Let's say we have 3 different mothers and they're thinking about HPV vaccine for their child, for their daughter. So each one of them has 11, 12-year-old girl. The first mother is not even thinking about it. Like, nah, people around me are not really doing it. Why should I bother? Like, it's really not an issue. She has all these different vaccines. So she's at the obviously pre-contemplation stage. We should not be giving up on this woman. What we really should be doing is creating a relationship, communicating with her, providing her the necessary information, and supporting her along the way to answer her questions that she might have so she doesn't completely give up. The other case scenario, we could have a mother who also has the exact same daughter, but now she comes to your office but did not show up with the daughter. She's kind of contemplating, obviously, because she did not come with the daughter. She came on herself, but yet she's inquiring. So now we're also facilitating, supporting her decision making. And we could also have another example of a mother who has a 12-year-old daughter who came in with her daughter to just kind of learn a little bit more about the vaccine. And this is where we can actually kind of push her into taking the action, tell her, well, you're already here. Let's address if you have any questions, but let's kind of already give you the opportunity to get the vaccine because it's going to save you the trip. So the point that we're trying to make with this model is that we should be facilitating in helping the person get to that step further. And most importantly, focusing on the maintenance aspect of it. Doesn't necessarily mean you got the vaccine, you're good to go. No. Creating that relationship, having different decision-making people in this process along the way will support this decision process for long term.
Yeah, and I think that why I like this model is that it's extremely practical. And what Trialda described, the first mother was actually at this step. And she was saying, how we need to think about to push her one or more steps up to this scale. The second mother, the one that came to the doctor's office, but without daughter, she was already probably at this stage. And then we can think about a very specific action, or either is a communication, either is something else that can motivate her behavior to move into the action stage. And a third mother that stepped in the office with her daughter was really prepared for action. But she was not yet there because she came in, she brought the daughter obviously, so she is prepared to get the vaccines, but she has some additional concerns that you need to sort it out to push her into the action stage. And don't forget that maintenance is important, because even people that are following exactly behaviors that we would like to see need some kind of support to maintain that kind of behaviors on a longer run.
Now we're getting to a little bit more interesting stuff, classical economics. So what we are assuming in classical economics is that human beings are actually rational. And what does that mean? That means that we assume that when people have to make a decision, they have all the necessary information in front of them to make the decision. So whatever I'm trying to decide, I have all the information at the top of my hand and on top of my mind, and I am ready to make the decision. The classical economics also assumes that we will respond to incentives. So you kind of incentivize me with doing a behavior, I'm far more likely to do it. And we do have some good examples where this actually works, and where classical economics is very successful in changing the behavior. That can be done through taxation. Do you guys have taxes for alcohol or tobacco in your country? I'm sorry? Sorry?
Excise tax.
Oh, excise taxes. Okay, so that's one way of doing. Or if we also provide subsidies. So if we provide condoms, that's another way of incentivizing people to change the behavior. However, both of these examples say that they don't necessarily always work.
Yeah, I think that was a classical economics model, and 15 years back, when I was with Nadim and some of other colleagues running the course on humanization and health reform, we were at that time talking about advocacy and communication as a kind of two strategies to very powerful strategies to deliver messaging and to let's say, improve uptake of vaccines in the region or any other intervention. Apparently, through the years, the thinking on this overall dynamics of people's behavior and incentives that we're providing to them has changed very much. So I think we are now in a completely different stage.
Yes. So what we are learning from behavioral economics, and this is a newer field within the field of economics, is that people think in different ways. The behavioral economics is actually taking into account our emotions. It also is taking into account that we're not always rational people. We might have the information and we still do not make the right decisions. So even when we know, we do not act accordingly. But sometimes it's also possible just to assume that we don't have all the necessary information to make the right decision. So behavioral economics tries really to point out the role of our irrationality and our emotions in decision making. So let's see how we can actually use that. I love this example. Here we have different countries in blue and different countries in yellow. And what we have, the countries in blue are showing us the organ donation percentage. So all of these countries, Austria, Belgium, France, etc., have very, very high percent of people that are donating organs, about all of them in 99%. Countries in yellow have quite lower organ donation. Denmark 4, United Kingdom 17, Germany 12. I actually want to draw your attention to Germany, which is here at 12%, and Austria, that is in 99%. These two countries, linguistically, culturally, historically, very similar to each other, right? What do you think? What would be the reason that they have such a high difference in organ donation? Yes? Oh.
Well, besides the Germany and Austria, Denmark and Sweden are also confusing for me. Mm-hmm. So I have only one assumption, that it's compulsory in these countries.
So let me go through explaining. Very good thinking process. What really we're learning from this example, that countries in blue, the countries that have very high organ donation percentage have in their policies by default set up that they're becoming automatically organ donors. So the only way that they're not going to be organ donor is if they take that additional step to opt out of being an organ donor. On the other hand, countries in yellow have quite the opposite case scenario. By the default, and that's set in their policies, in the paper when they're being registered, that they're not an organ donor. The only way they will be an organ donor is if they actually opt in. What this is really telling us that human behavior is very much automatic. We turn on our brain cells when we have to make a very hard decision. We make the decision and boom, we go back to our default automatic thinking. We are in our nature very lazy. I know that we like to think that we're all deliberate thinkers, Aristotle, Socrates, doesn't really matter, but that's not our reality. The fact is that majority of our thinking is really automatic. It's the lazy way out.
Yeah, I think this is a great example, and it comes exactly to your point. This is a great example of how you can have a really national policy that relies on this bias in a people's behavior. And because if you're born in Austria, you are becoming automatically organ donors unless you opt out. The different situation is in other country. And in all our region, we have a very similar situation with the mandatory or non-mandatory immunization. So we can discuss this issue later on, or maybe tomorrow when we have a side session on immunization. Also, it's important to stress that a couple of countries, and this is particularly the case with Netherlands and United Kingdom, they did a strong campaigns. In Netherlands, there was years of campaigns to get more people involved in the donors, and of course, the culture in Netherlands is not much different from the culture in Belgium or France, but they were not successful, or actually, all they managed is to reach up to up to 1/3 of population.
Yeah, that's the power of the information. So we assume, it's been really assumed for a long time, that as long as we teach people what they need to do, they're going to change the behavior. Well, Netherlands is a beautiful example of that can work only so much. Because what we're doing here, they were sending people letters saying, organ donation is really bad in this country, we need to do better. And they're giving them all this information and stats, what's happening. That brought them only to less than 30%. So information alone is not enough. And big organizations like WHO, USAID, World Bank, we're all recognizing that we really have to implement the behavioral changes on a greater scale, greater level, and have slightly more complex approach to achieve that for a long term. Second way of thinking, socially. So I want to exemplify this with a real field research experiment. This happened in a country where HIV was a big issue. So researchers got along and they go to a country and say, okay, we really have to learn who are the people that influence the society if we really want to change their behavior about HIV and using condoms. So after doing some work and in the field, they learned, places like hairdressing salons are really happening. That's where people gather. So let's use them, right? They would want to participate. Yes, I'm sorry, to distribute condoms. So they go to the different group of hairdressers and they divide them in 4 groups. And they explain to each group exactly what's going on. They say, you know what, in this country, HIV is really a big issue. We really want to do something about it. We need your help because we know that you guys influence this society. So we want to ask you to provide condoms. So the first group they approach, they tell them, we're going to ask you to sell condoms, and of all the condoms that you sell, you're going to get 10% back. They approach the second group of the hairdressers, and they ask them, we want you to sell condoms, and of all the condoms that you sell, you're going to get 90% of the money back. They approach the third group of hairdressers, and they ask them, you know what, we're not giving you any money. It's not the point of our work. But what we're going to give you is the star that you're going to be able to display in your hair salon. So everybody will know that you participated in this campaign of selling condoms. And them being good researchers, they had to have a control group to know that everything is being properly done. So that was the campaign. The researchers left. They came back a year later. And what did they find? What do you think? Who had the greatest success of selling condoms? Any takers?
Yeah.
Large?
The one with large monetary reward.
Okay. Any others?
Ladies first.
The third group.
The third group? Okay. Any reasons? Any others?
I guess the picture kind of it basically tells us that the hair salon is doing better. But I'm wondering, what if you are bald?
Which group? 1, 2, 3.
The third one, I guess.
The third one.
I should have probably removed the title for the next time because, yes, to make this, to kind of get to the point of this, you're right, the title gave it away. But our intuition, like our first colleague suggested, would make us think, well, if I'm going to sell condoms, getting 90% back is going to make sense that you're going to sell it most. No, that did not happen. You're right. That did not happen. The group that got social recognition display in their hair salon sold twice as many condoms than any other. But that's not the point. The point is that the control, large and small monetary rewards, did not do any different. When they did the data analysis, there was no statistical difference between these three groups. What this is really telling us is that we are human beings who like social recognition. We like to know that what we're doing matters. We like to get that pat on the back, good job, because to us, we're wired in such a way. If we have a reason to wake up in the morning and know that we're contributing to our society, we're far more likely to do the job than just getting the monetary reward.
I have to be totally politically incorrect in this, with this point that you are making. Yes, I think the behavior economics and behavior science is relatively new, but some of these stuff are actually used in the past. And if you remember, some of you who are over 50 or around that age would remember that in the Soviet time, this issue of social recognition was used very extensively as a powerful incentive to people in different areas. In our field of health service, in labor, in the industry, in the sports, everywhere. And it was, so what I'm saying right now is that the new model of behavior economics is also relying on some stuff that really worked in the past. So when we're thinking about new examples, let's have that kind of experience in tradition somewhere in mind, and let's see how we can use it right now in a different framework.
And I should probably emphasize this. The behavioral economics does not blow up the classical economics. That's not the point. It just says we really should be accounting for some other stuff, like our emotions and the fact that we are wired to respond to fairness and that we are not always rational like we like to think.
Yeah. If you want to change my behavior, coffee is extremely important.
And then the third way of thinking is through mental models. And I will just briefly go through this by saying that mental model is always perpetuated. So if I am a mother who has a daughter and people around me are believing that vaccination is not a good thing, I am very reluctant to accept the new knowledge because that behavior is continuously perpetuated. So we have to take this into account because whatever behavior we perform and the results that we get, that injecting the new behavior has to be very sensitively done. Otherwise, I'm just going to be going in a circle repeating the very bad behavior that I am performing. Obviously, if the behavior is good, like doing vaccination, that's a good thing. But we should be aware of this thinking process, the circular motion, because we have to be aware of when we're making policy changes. Ooh, I love this. So social marketing was built on the concepts and approaches that was done in commercial marketing. The point of commercial marketing, it says, we know what you want, what you need, and we're selling it to you. So it's selling you the goods. It's persuading you that you need those goods. The social marketing is using that exact same approach, but what they're really doing is selling you the product that is a public good. So the 4 Ps from the commercial marketing, the product, the promotion, the place, and the price is translated into the social marketing model. But the product might not be something fancy that we're selling in the commercial marketing, but rather is the behavior that we're trying to influence. What I really have to emphasize in the social marketing, and this goes also for the commercial marketing, is the research of the population that we're trying to influence. It really makes no sense of using this behavioral approach unless you do really into depth research of your population. You have to know what is that they like, what is that they dislike, what is the way that they're communicating, what is the way that they're behaving, how can you best intersect their behavior and change it, who influences them, who is the key person that they are going to listen to, what is the platform that they're using today. That might be social media, before that could be some church local going or whatever the event might be. You really have to learn as much as possible about them and know how to orient your behavior change to that population. That's something that we call formative research and tactical segmentation. Those are just technical terms. Do not pay attention to them. So that is the product, the behavior that we're trying to influence. The promotion is the way that we're doing it. The place, again, the location, whether that is online or actual physical facility, and a price. Price in social marketing doesn't necessarily have to mean the actual cost, like how much is something costing them, but rather the cost of doing the behavior. So if it's smoking, now asking them to change the behavior of not smoking. And here I actually have an example of social marketing campaign. Just to know, I talked to the translators. There is no, there's just the music in the background, but the words will be translated to you. It's only a minute long.
The Marlboro country.
Must you really smoke?
I love it so very much.
That sucks. I need a cigarette.
Can I get one of those?
Give me one of those, will you?
Can I get one of those?
Dentist recommended. Makes your food taste even better.
Mine turned out to smoke it.
Don't smoke it, darling. You just have to hold it.
Who got a cigarette, man? Anyone got a cigarette at the bar?
I don't know if you had a chance to see that, but it says, images have impact, let's change the picture. So,
no, I just wanted to make a couple of points here. I hope I'll capture what you... I think we came to social marketing because we realized that in some interventions we were not as effective as the private sector, as the marketing. And this is a great example how the tobacco industry adjusted strategies to the situation. So we banned the commercials of the smoking or commercials of the cigarettes into the cinema on the TV, but then they found a different way to market a product to this association with extremely popular people from the TV, and actually they started, instead of selling cigarettes, selling you a kind of behavior. And a couple of points. So marketing in private sector was extremely important and efficient, and we tried to learn from them and applying the best of their approach. What Rialda was saying, the segmentation of the market, understanding, deep understanding of what is really a factor that changing people's behavior, and then wrapping up this message around the public good and targeting. This is extremely important, and if you remember, the first example, one with the alcohol and driving, they were not saying don't use alcohol. They were not focusing and telling you to stop using it or whatever. They were focusing on this narrow problem, which is alcohol and driving, that caused so many deaths in the U.S., and they were so efficient in actually reducing that. So this is how we came, again, to this complex issue of a social marketing. So we learn from the marketing. We should not also undermine that in many areas that we are working, there is a marketing ongoing from the private sector. I mean, we need sometimes to counteract with marketing from the industry. And in the next session, I will be partially talking about this. But this is a marketing for the public good. We just use the similar approaches because that approach being very effective.
So
and I'm sorry, what is also important to stress here is that you need a very high expertise. So you need expertise and you need money. I mean, it's not always cheap, and it's not easy to get there. So you need to be prepared for it.
What I wanted to draw attention in this example is the product itself that they're trying to change. So when scientists got together to do this, this was done by sociologists, psychologists, behavioral scientists, and even economists. They were all putting their brains together, trying to actually do a proper research of the key influencers. And in their analysis, what they learned, the population, and that's going back to that tactical segmentation, segmenting your audience that you want to change their behavior, they learned that the greatest impact they can actually have are what we call today millennials, people in their late 20s, early 30s. So if you see this campaign, that was not targeted for somebody like Dragoslav, no offense, but it was really targeted for people that are younger who are streaming. So because TV is not cool anymore, now we're streaming and watching all these TVs, and they're saying, let's change the image. So this might have been seen as something great, but we actually have the power to change this smoking percentage, because millennials have been recognized as the generation that is ready to take action and have something, quote unquote, done. So that was why it was marketed in such a way. Okay, now I have a task for you. I'm going to read two statements, and I would like to ask for your participation to tell me what kind of impact these two statements have on you. So the first sentence is saying, flu shot is effective in 80% of cases. The second sentence says, flu shot is ineffective in 20% of cases. Can I please ask for volunteers to tell me what kind of information I'm providing you with these two statements? Thank you. She says the same information. What I wanted to give you with this example is how we say things really, really matters. The positive message, the flu shot is effective in 80% of cases, is exactly the same as the flu shot is ineffective in 20% of cases, which is really trying to emphasize information alone is not enough. We like to think it is, that if I give you the same information, you're going to react in the same way, but that's not the case. People who hear the flu shot is effective in 80% cases are twice as likely to go and perform that action of getting the flu shot as opposed to those who hear the negative message. So this is called positive framing. So what I'm trying to make you think about, the way that we say things really, really matters. The same thing happens when we try to debunk the myths. If you have a mother who comes with all these myths that she's hearing from her inner circle, we want to address it in specific order. We want to address the facts first and tell her, this is the fact, this is the fact, this is the fact. And then address the myth. The reason is we're wired in such a way that the facts and the things that we hear first are far more salient, far more likely to resonate with us than whatever is coming next. So the order matters, but so does the positive messaging, the framing matters. Does that make sense? Okay. So we're dumping all this information on you. We know there are all these different models and examples, etc. So let's give you some more practical ways that you can be utilizing this. Okay? So, recommendations. It may be kind of intuitive that physicians should be recommending whatever the preventative care measures we want them to do, like telling patients to come in for the blood pressure measure or getting the vaccines. Yeah, that's not really happening, not always. And there are different reasons. In one study, they found that physicians who talked to young women and their mothers and recommended HPV vaccine, those women or the young girls were four times more likely to get the HPV vaccine. And you may wonder, well, why then is that not being done? And there are multiple reasons. The worrying about the side effects, not feeling comfortable to address the issue of the HPV, the fact that we tend to associate it with the STDs instead of communicating about the impacts of cervical cancer, etc. But the bottom line that I want you to get out of this is the communication aspect, building the relationship and communicating openly with the patient. This is what's going to happen. Because if the physicians are not the ones doing that, guess what? Nobody else is going to do it. So communications and recommendations do have an impact.
And I think in a previous session on politics, I think there was a comment maybe from you whether trust and integrity plays a role in politics. And this is where we need to factor in the trust in a health worker and integrity of a health worker. And in a number of surveys and studies that we have done, the health worker is the most trustful person. You know, you need to be aware of the power that, basically not you, but our colleagues that are working in the field or working directly with the population, of the power that your recommendation, your integrity has on the people's behavior. You know, I mean, if we show that we are not fully into something, that will be transferred to the population, and that will affect their behaviors. And on specific example of HPV, I hope we will have a time to talk a bit more about that. If not, we will do it tomorrow. We also realized that there was a whole group of health workers that are gynecologists and obstetricians that started getting involved in discussions around the HPV vaccines, and they were not aware of the vaccination and they were not engaged in other vaccination programs. So their views were a little bit out of date and probably created a lot of hesitancy among the population.
Next example, and we hope we kind of demonstrated also by the organ donation, is changing the policies and behaviors into default. Pre-scheduling. You know, for me, I know if I don't have pre-scheduled dental appointment or preventative care measure appointment, I am far less likely to go. And what we have learned, people who have pre-scheduled option of getting the immunization or going to their blood pressure checkup are 3 times more likely to actually go to that preventative care measure than those who do not. Because again, default works, our automatic approach works. And we're not telling them that you cannot opt out. Obviously you can, but if it's set already in the system, we're far more likely to engage in that behavior if it's already scheduled for us. And this is sort of associated with implementations and intentions. And I actually really like this example because we have more than a couple of decades of experience with this through Nedim's work. So you might know he is an emergency doctor, but when he was initially in training, one of his jobs that he was doing, he would go from the city and he would go to rural areas to provide the vaccinations, immunizations for kids. And in order for them to be successful, what they were doing, they would actually announce specific date, time, location, what patient population will be coming to get that vaccine. And guess what? Now we have research to back that up, that people who have these specific implementation and intentions, like exact date and time and the vaccine that they will be getting to get that immunization, they are 40% far more likely to go through the immunization program and preventative care measures program than those who do not. I think that's quite fascinating that just by knowing the specifics, we're likely to increase the behavior. Reminders. We have technology. Who here has a phone? Smartphone? Anybody? All of you? Right? So, good. Thank you for raising your hand. That means you're awake. That means that we can actually use it to our advantage. So if we have these reminders to do the activity, given how chaotic our lives are, we're far more likely to engage in behavior. But that's not the only point. The point of reminders is actually maintaining the behavior. So saying, good job, you got to your preventative care measure, you had your blood pressure measure today, because we learned that if we engage in our participants, in our patient population, whatever that might be, they're actually going to respond. It's not just that we're asking them to do something, but if they know that there is connection between us, they're likely to come back. So maintaining the behavior is actually achieved through this manner too.
Actually, there is a great example. Is this a Georgian table? Okay, mix. All right. There's a great example in Georgia. They have a very good electronic immunization system, and part of that system is the SMS reminders that are being sent to the parents to come for the immunization, giving them a date and which vaccine child needs to receive. And it was exactly what we discussed with the colleagues in NCDC in Georgia, is to introduce one more SMS after the immunization session to actually thank them for coming, and if you remember those scales, to keep them on that maintenance level, and I think was extremely useful example. It's also example of how we can use technology which is really available everywhere, and you can easily do it in every country in the world.
Ooh, this is fun. And the reason I really like nudging, it's being used more and more, is because we're not telling people you do not have the same options that you had before. We're not taking any choices away from them. We're saying, no, all the choices that you had before are in front of you right now. But what we're trying to do when we're doing nudging, we're just kind of trying to give them a slight push, like, you know, this is the behavior we'd like you to go into. How about you participate? And you may wonder, does this work? So how did this came into existence? Obesity is becoming a huge issue, not just about adult population, but also among the younger population. I learned prior to coming to Armenia that it's also a double burden in this country. Interestingly enough, the malnourishment in the form of overnutrition and undernutrition is seen in children in age less than 5 years of age. And interestingly enough, it has 16% of obesity in that age population, which is even higher than in the United States. That was the shocking information that I learned. So what did scientists do about the nudging and the child obesity? They've seen that different scientists have different approach. Removing sodas from the school cafeterias, using different taxes, different incentives, etc. But behavioral economists approach this slightly less. They said, you know what? We're not going to take your sodas away. We're not going to take your pizzas away. We're not going to take your cookies away. They're all staying in your cafeterias. But what will we do is that we're going to put those just a little bit further away. So the first thing when you get into that cafeteria is going to be fruits, vegetables, water, so things that we consider to be healthy. And you know what happened? Kids actually ended up choosing the very same food. That kind of counts on the fact that we like the easy access, we are lazy, we're going to behave by a default. So if something is on my eye level, I'm far more likely to go and grab that than going 10 meters down the road and having to grab that Coke. I may as well have water, it's right in front of me. So that's what nudging actually ended up doing in this case.
That's extremely powerful because, simply and this is again what is coming from private sector because, when you are in the supermarket, when you get to the counter, they put some very specific goods that they would like you to pick up on the way out. You may need it, you may not, but another example here is that, and I want to link it to the point how information is effective or ineffective. You would know that over the past couple of years, we were in many countries introducing nutrition information on some products. So particularly in the US, you ended up with such a list of different information on nutrition. It contains so much of this, so much of that, percentage of this, and then there is a whole list of ingredients in the product, and apparently it ended up with nobody reading this kind of stuff. So example of how nudging would be dealing with that kind of situation is basically to provide you a color code. And they would say, they would put only one, either red, green, or yellow on the content of fat. So you would know whether if the product has a content of fat in red, that means it's very high. If it's in green, then it's a low fat. It's a more kind of more healthy product. So again, what we are saying, it's important to keep all options open to the people because the people also reacting when you cut them of different options. But you find a way to push them in the right directions by some of these interventions.
Now we're going to switch gears and go to our third task of today. If you remember, I tried to say that we're going to look at one specific public health problem and how we can use behavior approach to address that problem. But let's first talk about the problem. It's vaccine hesitancy. Prior to saying that, I really want to say I commend Armenia for doing such a good job in having such a high immunization coverage, very, very good job. But what we are trying to do in all these sessions and general flagship framework on transitions is to point out, and I believe Santiago did a beautiful job of providing us with some examples, once that Gavi pulled out, what happened in Bosnia. Even though that was a country that had 95% coverage, now it dropped to 75%. So we are using this opportunity for this to be a lesson learned from other countries, what could happen, because the rule is what can go wrong will go wrong. So let's kind of account for that and do not have that same bad experience. But prior to going to that, I would just like first to explain the concept of the vaccine hesitancy. And this is coming from WHO, that it says that vaccine hesitancy is a phenomenon that occurs when vaccines are available, but people do not want them, people do not use them, and that can vary across place, time, and vaccine. What is important to point out here, the majority of people are at this left side. They accept the vaccines, and they accept all the vaccines. Small group of people refuse all vaccines. And they really are not of interest because we obviously do not want to change opinion of people that accept the vaccines, and changing the opinion of those who refuse all is really hard. But what we really are targeting are people in between these two sides because they're the ones that are so-called fence sitters. They're the ones that we can influence, and they're the ones that we can change their behavior. You may wonder, why are we talking about this? I believe through this course, we mentioned it a couple of times. First of all, WHO has recognized vaccine hesitancy to be one of top 10 issues in 2019. That's a good reason enough, right? And another reason is that by joint reporting from UNICEF and WHO, 90%, this is 90, of countries in the world have some form of the other of vaccine hesitancy. And again, this is not a binary issue. It's not either or. It's rather a spectrum, a continuum. I may accept some, refuse some, and then that way may differ. So what we are trying to do with the behavioral approach is kind of move people to the left side. I want to emphasize this. This is a quite complex public health problem. It's not something that we can do within one session or a few minutes of this session that we have. And organizations like WHO and USAID have devoted extensive amount of time of researching this and provide different strategies and different. What I really want to emphasize is we have to take into account the behavior and the complexity of it, because what we have learned is that we have to take into account the psyche of people that are hesitant. So some of these examples that we were providing before, implementation intentions, reminders, changing default, all of these are taking into account whether people also hesitant towards vaccines. So taking whether they're complacent, whether it's convenient for them to get the vaccine, and using those strategies to address this problem. And now, Dragoslav is going to walk you through the health belief model of HPV vaccine.
Yeah, I think as you're saying, we cannot go through this model right now because we really have 2 more minutes, but we can use these 2 minutes to promote and to sell session on immunization tomorrow when we're going to continue this sort of discussions. And tomorrow we will also go through this model and take the HPV vaccines. If you remember, when I was talking about case of HIV/AIDS, a person feels that HIV/AIDS is a dangerous disease. A person knows that HIV, or there is a notion that HIV is a deadly disease, so it's a big threat, and you feel susceptible. Is it a difference when you ask a person about HPV? They don't see it as such a threat. So there is a one different that needs to be factored in. Do we have a positive expectations that the risk will be removed? I mean, we do know that if there is a risk of HIV during the sexual intercourse without condom can lead to transmission of disease. But we are looking into HPV in a different ways. So there are major differences that leads to different beliefs around the HPV vaccines, and we will continue these discussions tomorrow because we are running out of time.
I just do want to bring one more thing to your attention is solving complex issues like this really requires thinking outside of the box. And the reason I'm saying this is that some societies, some anti-vax societies are using social media. So there is a promotion of different vaccinations and immunizations on YouTube, which I believe everybody uses, and they're telling people it's a good thing to vaccinate, etc. But one specific algorithm was manipulated by the anti-vax societies. So after seeing that promotion that says vaccination is good, the next 10 videos that plays are all from anti-vax societies. It became such a big burden that the pro-vaccination campaign completely removed their promotions from YouTube and started using a different channel. What I'm trying to say with this, thinking outside of the box and knowing how to manipulate and use resources that are at the tip of your fingers is really, really helpful, because you have the power to implement knowledge, provide information, but also address the myths and knowledge of other people. So use that to your advantage. In summary, what we tried doing today is kind of just pique your interest, tease your brains about behavior and how it matters, what its role is in the health systems reform. We showed you different approaches, and the names, as I said, do not matter. It's just different strategies to change that behavior. And then finally, we just slightly touched upon a specific public health problem and behavioral strategy to address it. And I would just like to finish with saying these three things, is that with our key messages and take-home messages, we can achieve more health through behavior change than any other approach. This is really going not just within the health sector, but taking into account other sectors. And Nedim always gives so many examples from the seatbelts, etc. So please use the behavior. It is really wasteful to conduct a health system reform if you do not take into account behavior. You may as well not do it. So do take it into account. Do not ignore it. And finally, people will behave whether we like it or not. We all have our habits, our knowledge, our attitudes, whatnot. So use it to your advantage. Use it to achieve that public good and public health. Thank you. Any questions? Thank you.